So how do we examine our patients? Well, a full arteriovenous assessment is always appropriate. This is the classical paradigm for assessment of any patient, where we inspect the patient, we examine the patient with palpation. Occasionally you need to auscultate the patient, but admittedly not as much in arterial disease in the lower extremities. And there are a number of tests that we can do, and then we also can't forget the complete cardiovascular assessment of the systemic system. So when we look at the vascular limb, we want to look at the colour. Is it perfused? Is it a red, healthy pink colour? Is it a white, acutely ischemic colour? Or is it black due to impending necrosis or gangrene? Here we can see in the lower extremity, we can see that this is the patient in normal orientation. And we can see on the left lower extremity, we can see some venous flaring. But on the right side, as this patient is standing up, the leg is a little more swollen, which is not classical of arterial disease, but is a bit more rubor, suggesting that the patient's standing dependent, and this is a bit of stagnation of blood. In this slide we can see that there's clear cyanosis of the left first toe, and this may be related to major limb arterial occlusion or even vasospasm of smaller segments, and could potentially be reversible, such as a Raynaud's type phenomenon. We can see more advanced disease affecting the whole foot, and this could even be mottling which is not fixed and therefore is still potentially reversible. This is a slide that I always put up, and if we look at this patient is his legs facing you, and if we look, there's a pale foot on the left and there's a red foot on the right. And the reason I put up this slide is that either limb can be the limb with arterial insufficiency. And what I mean by that is that if you elevate both feet with the patient lying on an examination couch, the left limb is going white, which would suggest that it doesn't have enough perfusion when at elevation, and therefore that would be deemed to be the ischemic limb. However, if you ask the patient to elevate their limbs and then get them to throw the legs out dependent on the ground, you can get a dependent rubrous discoloration in the limb, and that is suggested that that limb is affected with arterial malperfusion. And therefore you could suggest, depending on where the patient is, that the right lower extremity could be the ischemic limb in this picture. Just important to realise that during all aspects of your assessment. Therapeutic changes. Shiny skin can happen for various reasons. If you have someone who's got a swollen limb with congestive heart failure, the limb is often very shiny with thin skin, particularly seen in elderly ladies. Hair loss is something that I look for, but more presence of hair. If I see someone that has hairy toes, then that suggests to me that the arterial supply is satisfactory. There's also ulceration at pressure points. Arterial ulcers tend to affect near bony prominences, and that can be the lateral side of the foot, the head of the metatarsal and the plantar aspect, the heel or the malleolar regions, as well as in the tips and in between toes. Venous ulcers tend to happen slightly more proximally between the tibiotuberosity and the malleolar region, and that would be the gaiter area. Here we can see dry necrosis of the tip of the left second toe. Here's more worrying probable abscess formation with necrosis affecting the right second toe and metatarsal region, with spreading of the disease more proximally. This would worry me a lot. Here's a chronic right first toe wound, which is trying to demarcate with dark necrosis at the tip of the first toe, with a transition zone which is probably some inflammation and sepsis to viable tissue more proximally. This is a lower extremity that presented to me recently. You can clearly see the patient has attended podiatry recently, as they have had some treatment to the medial aspect of their left first toenail. But this patient clearly has a large ulcer around the first metatarsal area, and you can see that this patient has been in some intravenous antibiotics as the swelling has reduced, as shown by skin blistering, but you can still clearly see that there is nidus of infection still present. This is a lower extremity that I actually reviewed in Altnagalvin Hospital as a visiting surgeon up there during my clinic on Mondays. This is a gentleman who is known to have type 2 diabetes. He is profoundly neuropathic, and felt the need upstairs in a house that he is renovating to walk about barefoot, where there were large bore nails sticking up through the wood, and he stood on these repeatedly. You can clearly see a number of puncture marks and an area of necrosis in the mid-central aspect of the plantar surface of his right foot. He proceeded to have direct transfer to the Royal Victoria Hospital with an incision and drainage the following day, and actually has made good recovery as he has palpable pulses and is a non-smoker. Here's a chronic wound affecting the lateral aspect, 4th and 5th metatarsal heads. You can clearly see that there's some disordered architecture in the right foot, particularly in the mid area of the foot, and the patient also has a previous left transmetatarsal amputation. This would be a significant concern for me, as there is clear evidence of arterial malperfusion as well as ongoing diabetic foot ulceration. Once the heel is affected, this is something that always worries me, and regardless of this being dry necrosis of the heel, I worry extensively for any break in tissue in the heel area. And this patient has spent a long time in bed following a hip repair, and they have dependent ulceration, as you can see, not in the plantar surface, more as we're heading up towards the Achilles tendon. We want to feel the temperature of the skin, but often a diabetic foot can feel warm. This can be misleading, or if you've got infection in a foot, it can also be misleading. Capillary return I still feel is a sensitive modality. Again, this is purely revision for most of you. We want to examine all peripheral pulses. I particularly am keen to examine the femoral pulse because I'm not only a vascular surgeon, I'm an endovascular specialist. I do my own angiograms, and palpation of the femoral pulses allows me to identify whether I have an access vessel for any potential endovascular intervention. The femoral pulse is palpated midway between the symphysis pubis and the anterior superior leg spine. Generally what I tend to do is I place 4 fingers in one hand and 4 fingers in the other hand and place them towards the groin crease, and one of those fingers usually identifies a pulse or a thick tube suggesting a calcified vessel with minimal pulsation if very diseased. The popliteal artery is examined with the knee slightly bent, and I personally place my thumbs in the anterior aspect of the knee and place all 8 fingers from both hands into the popliteal fossa. Again, my personal feelings is that if you can easily palpate the popliteal artery, it would be suggested that it's aneurysmal. The posterior tibial artery is palpated midway between the medial malleolus and the prominence of the heel, while an imaginary mid-malleolar line towards the web space of the first and second toe delineates the dorsalis pedis pulse. There are a number of traditional bedside evaluations, and I do believe these are still very sensitive. If you want to look for arterial insufficiency, why not elevate the leg if the patient doesn't have any hip pathology? You can look for venous guttering, but more importantly look to see if the limb goes pale. Berger's angle is an adjunct onto this, where you elevate the leg, and the point at which the leg becomes pale, you look at the straight line of the table up to the angle of where the leg is elevated, and that is Berger's angle. This is Berger's angle, clearly identified at approximately 30 degrees on the left foot, which goes pale. To progress on, you then have Berger's test, and Berger's test is essentially where you elevate the leg up, you identify pallor, and then you ask the patient to shuffle over to the side of the bed and throw their leg out over the bed so it becomes dependent. And then you're looking to see if there's reactive hyperemia where the foot goes a purple colour, and this is then termed Berger's test positive. And here we can see the left foot becomes hyperemic. Again, it's also important to check blood pressure, particularly if this is uncontrolled, and also it's useful for auscultation of the heart to listen for an ejection systolic murmur, which may be consistent with an aortic stenosis, which is issues for any operative intervention. I always palpate the abdomen as a matter of fact to assess whether there's an aortic aneurysm, but I appreciate this is quite difficult if there's a raised body mass index.